the planet. So today we are speaking about sustainable ophthalmology, and I'll give a short introduction, and then I'll talk about facility design and management. And we have Dr. R.D. Ravindran, who is speaking about minimizing the environmental footprint of ophthalmology at a tertiary eye care center. And if the tertiary eye care centers through which a lot of trainees go, it should be part of the curriculum, saying that tomorrow they should also be mindful about what they are doing. And then Somshila Murthy is here to give us tips to how to make our practice and learning green. And Vinit Joshi will tell us how technology is the way to go forward and try to make the effect. So why sustainable ophthalmology? As all of you know, that global warming is a fast coming crisis which all of us are not really taking it seriously, but in a few years our children and our grandchildren will face the brunt for the mistakes or for the foresight which we did not have as a collectively as this one. Pollution is another aspect, chemicals, pesticides, plastic, which we have to be really aware and try to minimize it as much as possible. And all this also is resulting in biodiversity loss, which is also resulting in options as to treat our problems. It's not the planet which is at risk, it's we who are at risk, and for our own sake we have to do all this, because that's a threat to our health and future well-being. As the Hippocratic Oath says, first do no harm to the patient. So we should also take that, extend it forward, and make it that we should not do any harm to the planet. In fact, there's a organization which is called iSustain, which is supported by AAO. David Chang is the one of the persons who's heading that, and ASCRS and ESCRS have formed an iSustain, and I think we should talk to our AIOS brass who will get elected next time and try to join that organization and try to make sure that we combinedly do all the efforts. There's another organization called Physicians for Social Responsibility to promote awareness of sustainable practices. I think we should collaborate and on a global scale do this, because we have so many people, the largest population on earth, and we can contribute significantly to that. And all of us know that circular economy is the way to go. We have to reduce our use, reuse things and recycle them, and always being mindful, right from switching off a light, turning off a tap, and all those things. So I'll talk shortly about sustainable ophthalmology, how right from the time we think of a facility, think of a profession, how it can help about with the design and management can help in decreasing the footprint. So right from the time we think of a hospital, the building design has a major impact on the environment through its lifetime. So India has a good green buildings code, and then we have to adopt it for hospitals too, because the material what we use, the processes which have been used, the designs, the insulated windows, walls, planting trees, all this is right from the time a person knows about ophthalmology, we have to plan it. And also running a hospital or a building or in our lives, energy, water, waste, food, transportation, all these things are part of our day-to-day thinking process, and we should make sure that all this happens in a green way. Operating room protocols is one. Then the day-to-day usage, that the lights what we use, the AC environment, the amount of, for example, the government of India was also planning to have 24 degrees as the cutoff point. We sometimes put it at 18 and use double the energy. Then mobility, fortunately EV is picking up, and electrical vehicle mobility will help us in future. And then renewable sources for electricity generation and conserving whatever energy we are using are some of the ways forward which can give us fast results. Usage of water, which again we are facing a shortage and it's fast coming. Reduce your usage, try to harvest the runoff, recycle and recharge groundwater when needed. Waste is a big thing which none of us are looking at, but there are ways and means which everybody is trying to help, and Dr. R.D. Ravindran will talk more about it, about how to minimize, recycle whatever waste we are generating. And I've been trying to coordinate with companies, trying to say that their packaging and they should take back their high quality plastics what they're using. And some of them had atrocious answers. This is the municipality's work, not my work. So you generate the waste and somebody else has to use that. I think all of us collectively should talk to our companies. Biomedical waste disposable will help us with our health, and encouraging plant-based foods, all of proper storage and avoid wastage, so that way vegetarians are helping the planet. Avoid fossil fuels. Ethanol for generators can be used. Charging infrastructure should build up, and avoiding chemicals in our environment, both in the OR as well as for pesticide management. And we have to sensitize our staff for energy usage, water usage, and resources usage, because all of us are part of a team. And then electronics are a big thing now. We use so much electronics, and we should know where they are going. Try to not use the latest models and keep recycling your products. And then energy efficiency can be improved by appliances. And thank you very much. I tried to give you an overview, and Dr. R.D. Ravindran will give us a very interesting talk. Yes, please. Yeah.
Now, disposable of the high-tech waste is also there.
Yes.
Man don't know how to disposal. Man knows how to where to dispose, but he's not doing it. See, what I told you, there are lakhs of satellite they expect. What I told you, they all been brought to Arctic region, where technological kilometers nobody is there. Now, what they have done, they have diverted them, and they have buried in the sky. And they will reverse cycles, and they will fix the
Yeah. Whatever goes up will come down, sir, someday.
Man don't know what to do. First they told they will bring it on. Now they are buried in the sky. Whatever the advanced management, but he is not following. Man knows good and bad, but how to avoid the bad also. But he will be continuing. Just take drinking alcohol, sex, other things. Everything man knows.
Yeah, we have to know how to change human behavior. I think that way we'll have to scientifically use this. Sir, we'll have our questions towards the end, because we are only few people. It's more like a group discussion. There'll be a lot of questions generated. We have enough time. We'll discuss at the end. Yeah, thank you.
Yes. So like good afternoon. So I'll just share now how we minimize the environmental footprint of ophthalmology practice within through Aravind Eye Care system. So that's a thing I've taken. So the need for eye care is it's really exploding. So is ophthalmology one of the high volume outpatient specialties, especially because many of the diseases like glaucoma, ARMD, diabetic retinopathy are all becoming chronic diseases. We are also in a way perpetuating that with the medical treatment and injections, so that makes a patient visits at regular intervals. And again, cataract surgery, as we all know, is the most commonly performed surgery in any part of the body, and it's also has got a high disposable supplies and material component. All of this, and again, ophthalmology also is a very high volume surgery because the surgical time taken is very less, and we also have found a way how to be efficient. So all of this, makes eye care very important. Just to give a brief idea about what is carbon footprint, whenever it's about the amount of gaseous emissions that are relevant to the climate change and associated with our day-to-day production or consumption activities. So this is like the gas emission when we use our vehicle, the exhaust that comes out of the car or the other vehicles, or when we cook, the gas which we use, and also the electricity which we use, which are generated using the coal. All of that is given rise to certain level of greenhouse gas emissions. And so any burning any fuel releases carbon dioxide into the air, which is we call as a carbon footprint. And for example, a cup of coffee, which has got like a 15 grams of coffee powder or equivalent, will produce zero point 0.4 grams or 400 grams of carbon dioxide. That's what it releases. A balanced diet, especially you was talking about vegetarian, 1165 gram of a meal will emit about 723 grams of carbon dioxide into the air. So there is a way they know how to calculate all these things, how much of carbon dioxide, which is not only about cultivation but also processing, transportation and delivery. All of that is taken into account. So in the same way, if you look at how they have calculated for the food, if you look at how much carbon, what is the carbon footprint for a cataract surgery, it is equivalent to about 180 kilograms of carbon dioxide equivalent in UK. This is equivalent to driving a car for about 500 kilometers, you can imagine. So that's the amount of carbon dioxide that is released from a cataract surgery. And over 50% of these things come from the supplies. Supplies contribute to the most thing. As you can see, the building and the energy use within the building contributes only to 36%, and the travel by both the staff and the patients contributes only to about 10%. So majority of that comes only from the supplies we use. So it really, it also indirectly tells us that how do we minimize the use or how do we reuse these things. And if you look at the global cataract surgery, in the recent years, it was like 26 million surgeries. Maybe the current estimate, probably with the annual growth rate of 3%, could be somewhere around 30 million cataract surgeries, and a majority is being done by phacoemulsification. And you can do the mathematics, calculate into 180. So that's a volume that has been released. So here I'm just sharing a paper that was published and was also presented in the American Academy, where we had a scholar, the first person, 1 minute. So Professor Thial, she is an environmental engineer. She had come on a Fulbright Nehru Fellowship. So there is a scholarship that is available both for people in America and also in India, who can go to either, Indians can go to America or Americans can come here and take up a field and study. And she had come and stayed with us for 6 months. It's like a 6 months fellowship. She looked at what is the volume of surgery done, and how much time we take, and what is the kind of consumables we use, how much waste we generate. So after each surgery, she'll collect all the consumables which are disposed, and which goes to the waste as a waste out of the hospital. She will measure that, and she'll also measure like a linen, if we are going to wash it and reuse it, she'll also measure that. So she took the weight of that, plus whatever we recycle, like a paper, plastic, all of that, or a glass bottle, all of that she measured when she was here. And the same thing she also did in 5 other hospitals in America in 3 different locations. And it also doesn't include any hospital specific or patient specific data. So among the three locations in America, in one location it was a hospital, ambulatory surgical center, and outpatients. Each one of that has got a different dynamics. So she has looked at all of that. In the Michigan, it was a Kellogg Eye Center, and there is a hospital in Maryland. I presume it is a Wills-Eye hospital there. So she at least observed minimum of 10 surgeries or more in each location from January to October. She was here for 6 months, and then next 3-4 months she spent in America. She observed at least 1 or 2 surgeons in each of the location. She also recorded how many staff were needed for each of the doctors or each of the procedure, the surgery duration, and the flow of material and the solid waste that was generated. And she obtained a detailed list of everything, and also she measured all the disposed waste also. She also observed the sterilization process. So as you can see here, these are all like a biohazardous waste. It goes to the really waste dump somewhere. So you can see this first 3 hospitals, everything was categorized as a biohazard waste and they're sent to a disposal facility. Whereas the fourth hospital, the one in Michigan, which is Kellogg, so they were kind of sending many of that. They were able to segregate the papers and all that, which went to the municipal waste, and they were also recycling some of that their supplies, whatever waste they were generating. But none of the other hospitals were neither sending it to the municipal waste. They are all going to the biohazard facility, and they are not recycling. And this is another hospital. Again, as you can see, part of that went to the municipal waste, and good amount also went to the biohazard. And whereas compared, this is a waste we kind of generated within Aravind Hospital. And if you look at the waste amount, it was like close to anywhere between 2.5 kilos to 5 kilos was generated in American facilities, and in India it was in Aravind it was only 40 grams. So you can see the difference that went out as a waste. And these are all the details, what she took for the same, whatever data I shared there, it's all here, but it gives a breakup of the waste, total waste, how much was recycled. And again, a large component of this waste came from the disposable custom pack in these hospitals. When they operate on a patient, they open the whole pack, which may even include a anterior vitrectomy cutter, many other things which they may not use, but they end up as a waste and goes to the either municipal waste or they go to the biomedical hazard thing. And this, here you saw that, there it was 180 kilograms. Here we generate only in Aravind 6 kilograms of carbon dioxide. This is like driving a car not to 500 kilometers, but it is 23 kilometers, and it's 4% of the emission of phacoemulsification. And she also compares if the American, the thing is similar to UK, and where they are all the surgery together, they are generating about 480,000 metric tons of carbon dioxide. It's also equivalent to driving more than about 100,000 vehicles for a year without stopping it. So that is for the people to understand that. Or she gives 70,000 homes using electricity over a year. Or it's you need to have about 450,000 acres of forest land to absorb this carbon dioxide. And she also goes on to say that if America uses like what Aravind does, it's about 18,000 metric tons of the thing. You can see the difference. Where is 18,000 tons and where is 480,000 metric tons? And all the other comparisons she gives just to make people really understand the impact of the waste in America, especially from one surgery contributing to the thing. So the main takeaway from her presentation, the paper, is that the healthcare and surgeries in particular are resource intensive in America and leads to increased emission, which are adversely impact our environment and public health. And there appears to be an increase per case spending and other factors. All this disposable also add to it, and they show that Aravind or any eye hospital in India, for that matter, is a model for that. So the main reason why the amount of waste is very low is that we also share supplies between the patients, and we also minimize the use of single-use instruments. And wherever possible, we also try to have a protocol of cleaning, drying and re-sterilizing it, and using these use instruments like your vitrectomy cutters, sometimes even the blades. And we also try to see that the supply chain management is also kind of a conducive in Aravind, because most of the supplies are procured within Tamil Nadu. And we also have a very robust waste segregation. Even when, for example, in IOL comes in a pack, you have got a paper component and a plastic component. That is also separated and it's also recycled. So because of all these measures, we are able to recycle a lot of that. So all the tubings, everything goes for recycling person. So that is one part. The surgery is one part, but we also have the access to the care, the patients coming to the hospital. There is also a carbon emission direct involved in diagnosing and advising the patient, and it's also in the follow-up. So all these activities also generate carbon dioxide. So this means there's the transport of the staff, visitors, procurement of goods, energy use, all of that. And so this is where it is important that we minimize the number of visits made by the patient to the hospital. So Aravind works on a non-appointment system. We try to have a paying and free, so that nobody, because they cannot afford, they don't have to go back without availing the services, and it's also open over a period of time so that people can easily access. And again, like LV Prasad and many other institutions, we also have developed vision centers. As a result, 90% of the patients who come to the vision center, they don't have to travel to Arvind. So, and when they come for surgery or investigations, we also structure it in the same way, in a way that they complete everything on the same day. Like a patient needs cataract surgery, their intraocular pressure is checked, their duct passage is checked there. They also consult with the local doctor for ECG, all of that. They come in the morning, there's a biometry is done, surgery is done, they go back. And the next day morning follow-up, they go to the vision center. And even for walk-in patients and paying patients to the hospital, if they are from a nearby vision center, we also advise them to go to the vision center for the first day follow-up rather than coming back to the hospital. So all this, this travel, when you reduce that much of carbon dioxide, because each patient is accompanied by another one or two patients. So that really minimizes the carbon footprint. So recently, the Public Health Foundation of India also looked at our vision centers, and they found there are about 9,590 patients. There are only about 590 patients needed to visit the hospital for a specialty referral. And they calculated that by avoiding. So if they took that, each patient will take a bus. About 60 patients can go on the bus. So that is how they calculated. So they say that we have avoided about 54 tons of carbon dioxide emission because of this process. So now if you put together the 100 centers across all Aravind, the contribution to the environment is much more. And again, the camp is also another great example where we minimize the number of people coming to the hospital. Through the camp, only the patient alone comes, not their attendants. Okay, and again, the post-operative follow-up visit is done at the camp. Here again, now we minimize the transport of so many patients. At least, 1/3 of the visits are also cut down. And again, 70% of our staff live in the campus. That again makes it much more environmental friendly. So all of this contributes to that. And again, the way we have structured is, there is each person does one work. So one equipment is put into use. Sometimes, if you have there is another model where the patient does not move, where you have to duplicate equipments in each of the rooms. So by here, the same equipment is where it is used for 150 patients. There probably it may be used for only 30 patients or 25 patients. So that way, the number of equipments used also becomes much. All of that probably also contributes to that. And again, the diagnosis and advice, if you make sure that you follow standard operating procedures, the system design allows all investigations to be done on the same day. Any opinion by a specialty doctor is obtained on the same day. And we also make sure that 80 to 85% of the glasses also delivered on the same day, and the patients are also admitted for surgery on the same day. So all of this again is towards minimizing the repeat visit of the patient, and again minimizing the wastage. So again, we in the recent years, all the new buildings we have built with the concept of a green building that allows natural ventilation, natural light, and all that. And we also try to be energy efficient. The recent years, at least in Madurai, which is the largest facility, we have completely changed to energy efficient system. So as a result, where we were consuming say about 10 lakh units per year, now we consume only 7 lakh units per year. So there is a 30% reduction in our consumption as well. So we also have gone completely, we have put solar panels in all our hospital. That contributes to about 78% of our requirement. But we also tied up the solar and the wind farms, and 90% of our energy supply comes through these units. As a result, our electricity bills also have gone down by another 30%. So both by adopting the energy efficient equipments, we were able to reduce it 30%, and by buying it from the solar, not from the government, again we were able to save a lot of money. And recently, this was taken up as a like a case study and presented in one of the American organization. And again, we also have a decentralized wastewater treatment plant. Again, the interesting thing about this is does not use any energy, does not use any chemicals. It is all made by natural things. There is a way of decomposing the sewage, and as you can see, these plant beds are here, which is in the bottom picture, and they, whatever you see, they are all underneath. That is our sewage water at the end of treatment, and that sewage water they comes out. You see a green on the other side is a pond where the water comes, collects, and its water is again reused. And today we recycle about 15 lakh liters. With the renovations which are happening across all our system, we probably will be recycling about 30 lakh liters of water. And again, food, we try to have a restricted menu in the canteen so that the food wastage is also reduced. In the hostel, if the wastage we find, if it is more, then we also weigh the waste and put it on the notice board every day, that how much is also being wasted. So to conclude, I think to reduce the carbon footprint, one is we have to reuse, increase the reuse, minimize the use of single use, and then how do we really segregate everything and see for recycling and using energy efficient appliances, switching to renewable energy resources, using less water, and also minimizing the patient visits. And we also need to share this with all the people. Recently we had conducted a workshop for some of the partner hospitals to see what how they can follow some of our best practices, because all this has helped us to save money over a period of time. And but it needs the commitment of the highest leadership, and raising the staff awareness and staff engagement, identifying and implementing opportunities, and taking the message forward. Thank you.
Great model, I think. World over, this has to be promoted, right?
Yeah.
Made aware.
The interesting thing is, Dr. V thought about this in 2000 when he put that sewage water treatment plant for the first time. Probably that time that was the largest sewage treatment plant in the whole country, where each day we were recycling 300,000 liters of sewage in Pondicherry. And but it really initially took a lot of money, but for the next 10 years we didn't have to spend anything. So only after 10 years we had to take it out, clean it and put it back. Otherwise, recycling was costing less than 1 paise per liter. So, and we are using that water for all garden and also for our toilets. And was also certified by one of the university, saying that it is fit for grade 1 agriculture, which means that water can be used for cultivating salads which can be eaten raw. And one person did his PhD from the Gindi University also, engineering university.
So this has to be part of the curriculum of the
Students, yeah.
Yeah.
At least in Pondicherry, we organize a tour for all the patients' relatives when they are waiting. Ask them, take them around and show them around. Yeah.
So, can you tell for each cataract surgery what are the disposables you are using at a glance for surgery?
See, the only thing we may throw it out after each surgery, may be the visco cannulas. The viscoelastics which we use, it's very difficult to reuse it. And the capsulotomy needle, the 26 gauge capsulotomy needle. These are two things which is not reused after any surgery. And the drape, surgical drape. The surgical drape, the capsulotomy needle, and maybe the viscoelastic cannula, because it's not easy to clean it. Yeah. Surgical blade is reused. It goes for sterilization and reused on the same day, and at the end of the day we dispose it. Yeah.
Typically, for how many cases is it used?
Maybe 3 to 4 patients usually. After that it becomes blunt. Yeah, does not last beyond that.
Yeah, we should have evidence-based medicine to say that, because typically they'll say, because sometimes if there's a medical legal case, there's something, we should have evidence to say that this does not cause.
Yeah. So that's why we have some of our publications on endophthalmitis where we talk about all these things, to show that this is not even reusing all the procedures. The incidence end ophthalmitis can be very low as 1 per 10,000 or 2 per 10,000.
The Western societies have been one aspect is about the IDOX usage. So most of the Western societies, and even during COVID, we had to follow that, but otherwise, reusing the drop against for more patients, not just one patient. So in the West, you just use it for a patient and then dispose.
Yeah,
So
yeah.
there's even recently a committee came together to try to propagate that if used correctly, you can use the same, or at least the patient brings in that drop and continues to use the same drop post-operatively. So is there something that you do?
Yeah. So we use it for multiple patients, and we also advocate that. I think there's some study design they have done to test this, that it is not harmful. So, and again, we are also challenging the 30-day usage limit. So we are trying to get patient coming back after 30 days. We are trying to take it, and we are also trying to culture that and show that that is it's not so.
Yeah, if that evidence is there, they
Yeah.
can ask the companies to say that not to
Yeah.
bring back, it has to be used. If they throw away, whenever the glaucoma costly drugs, they say that it should be thrown away. They keep asking us.
So
Yeah.
some of the glaucoma drugs are just single drop installation, and we can have that will come for more than 1 month. Then it says on the package that you should start after 1
Yeah.
month. So they end up, they get confused, and we want to say that you can keep it as long as it's good and you store it in a clean place. That's what I openly tell patients, that you can, as long as you keep it well, preserve it well, you can use it for longer than a month. But
Yeah.
obviously, you will feel a little apprehensive because of the packaging inside
It says, yeah. So we are trying to do the study with the patients who are willing to give the consent. So, okay, thank you.
Disposable of waste should be a fundamental knowledge of human being.
Yes,
Should be taught from education, not with that.
true, sir. True.
See, I'll tell you how manage my air pollution. Satellites are don't know how to manage.
Yeah.
And all ships, they go to the Pacific Ocean.
Yes.
So the floor of the Pacific Ocean is all ships, they throw the waste into the sea. Pacific Ocean, the floor is filled up with ocean is fine, air is fine, so everything is fine.
So most sons are not taught how to keep things clean. Daughters are taught from child. So most sons are not.
Mark paid December post paid is 200 pages disposable waste. 100-year-old textbook. That medical students read only for exam.
Okay. Sure. Thank you, sir. Thank you.
Yeah.
Dr. Vineet, you can, yeah.
Finally, they have been thrown to say river. These are all floating coming. Last month they got 10 lorry loads of medical waste in the river. This is what we are doing. We talked evening function, then we'll have more science. So, everybody.
Very, this is a very nice initiative, Dr. Madhukar Reddy. Amazing talk, Dr. Ravindran. It was an eye opener for me. I mean, really, the first slide which you just showed about 500 kilometer, that was like, I couldn't believe it myself. Like, is it, I was thinking in my mind, is it the motors that we use in the phacoemulsification? Is that, but it's actually the waste supplies, and this is something to really look into. That. But what I am going to touch base is a way by which you can actually go green by avoiding too much of transportation or mobility of patients due to appointment systems, and how the newer technology can help us in doing things from wherever the patients are and still giving a very good clinical outcome. So it's all related to telemedicine, but a little bit more advanced, like what else we are doing in that region. So I will not go into the depth of what we are doing in Center for Innovation and Technology, but the whole idea is everything is now digitized, and there is a huge potential in actually utilizing the softwares and tuning them for patient-centric experience using AI. So most of the, even if you see the trade stalls and wherever the AI is being used, it's all directed towards clinicians and the technicians. So that's where we are looking into how we can make it useful for the patients directly in the hands of the patients. So we can save physical visits and travel, avoid routine follow-ups, convert them to teleconsultations accentuated with videos, images, and also power them with AI, wherein you are also saving clinicians time over there. And have robust appointment system, make newer slots for newer patients. So what we were thinking AI would do, and when we talk about primary eye care, the image of AI changes. You need assistive software modules on a scalable platform. You need a very simple device which can be translated in multiple vision centers, but that has to run on AI. So it's not a very advanced tech, but it is advanced software with simplest of hardware that will reach to the community. So one of this was our smartphone device. I'll tell you why I'm showing this, because when we started this, we were thinking of making something really nice for the doctors, which will have a lens and light source. And but then we realized that the real potential is what if the patients use it. And we found out that the more complexity we put into the device that we make, the patients find it useless. I mean, for example, what is the use of a slit for a patient? If you're having a slit beam in your smartphone image capturing device, it's of no use to the patient, doesn't know how to use the slit. So we just removed the whole thing. We made it very simple. We just kept it as simple as that plastic hardware that sits on any smartphone, and we tuned our app in such a way that it clears off the problems of magnification, illumination, and focus. So all that patient had to do was go into the app, just tap on the screen, and their photo gets uploaded on the cloud, and the doctor is able to see from the center. So not even the need to go to a vision center. Directly it sits in the hands of patient at their home with their own smartphone, which they know very well how to use. All we did that, we just trained their relatives after post-op. That's it. Those 10 minutes we invested in them, and just look at all those images are captured by patients and their relatives. These are post DSEC, that is an infection post TABCL patient, and the outcomes are very good, very simple, very useful technology. And all we tell them is, just bring your black part within that white circle and just tap on the center of screen, job is done. So this is an image of the patient sent this without using our app and device, and then I asked them, please use both and just see the difference. So I could actually give them medications based on this particular image, and you can see there is one loose suture also there in the last image. So similarly, one more patient like this one. So this guy, during the COVID time, we had to do an emergency transplant for him. He was one-eyed and he couldn't follow up. So we trained his son on this device, and almost for 10 visits, 4 months, we could manage him successfully with this, until he developed an epi defect, when then I could identify it on this and we sent him down. Again, these are sent by the patient. This patient is taking selfies, looking in the mirror and tapping and sending these images, such beautiful images. Now why would you want to call him when he's sending you an image like this? And opposite to that one patient called me and said, I am having a white dot, and I was like, okay, send me a photograph. And we knew that this is a patient who actually needs to come, and you don't need to call the other. So you can actually filter through and screen. You don't need to call everyone at 1 week or 1 month. You can screen through. You can now actually triage the whole system. And this is what we did, our Connect Care, the teleconsultation app. So we calculated in overall that what was the environmental impact, especially during that time of COVID, that we generated. And what we found out was that we could save the travel cost of patient, which was up to 5,000 rupees per patient, which is close to $1 million US. And that also led to an environmental impact, as you can see in the last slide. That's up to 11 lakh of kg of CO2 emission. 1.1 million kgs of emission was saved just during that COVID phase, just because we converted most of these into teleconsults. So this is the team that has worked really hard behind in developing this grabby product. Now how do you make this better? So there are a lot of works going on in different institutes and groups, especially in China. And also I from Arvind, they have come up with an amazing AI algorithm for diagnosis of microbial keratitis lesions. We are also working on the same lines, and we believe that application of these is going to change the way we follow up the patients and see them even before they come to the clinic. And I'll tell you why. So this was one study which was they did in China, and if you see, they're trying to identify cataracts, no, OSSNs, infectious corneal diseases, the corneal degenerative changes, dystrophies, and normal eyes. So they are generating a data set by which it can actually identify the lesions that you want to see. This is something that we were working on, where we are using some latest patch based CNN to identify what is the white spot in the cornea and whether it actually needs a referral or not, whether it's a scar or whether it's an active infection. And it works pretty well if you actually train the algorithms very fast. So what I feel is that you need to train a new workforce which understands this. And it's no longer just medical and engineering community. You need to train them together into deep learning, AI, and also have combined mentors in hospitals and third party collaborators, where you can actually implement these solutions at your tertiary centers, secondary centers, as well as your vision centers. There are many online courses also, I researched about them. So if again, these things you can educate it right from your apex center, and you don't need to have a separate course for this. This is a very easily translatable technology. Another example what we are working with is post keratoplasty aftercare and AI chatbot. And this one is operating in multiple languages. It is able to identify all the symptoms of the patients, whether there is a drop in vision, whether there is redness, whether there is pain. And in that also, it just asks for your MR number, or it asks for your pin code, and then it will give you a geological location which is the nearest LVPI center that you can visit quickly. And it has a facility again where it identifies the image, sees it if it is really a hypercritical situation or not. So we are training this bot so that even if the patients are in an emergency and they cannot reach to the centers, cannot reach to the phone lines or anything, they can actually access this, and they can get a good advice. To that extent, there are some amazing algorithms which exist right now that can identify whether in a given image an eye is present or not, and eye is in good focus or not. So it just removes the need of a trainer also. So all the patients have to do is just take an image and everything will be done by itself. So that's where we are heading into, and we are actually trying to build a lot of things in that regard. Because time is up, I will wrap up. I just wanted to stress some base on this. Thanks. Yes.
That's really nice, actually. But you don't have a chatbot, huh?
Yes.
What about artificial intelligence?
Yes, so it will be used, these APIs will be used in that chatbot. So it will try to analyze, it's all how we train it to do. If their training will be to identify the most emergency hypercritical cases which needs consult. What we are trying to do is avoid consultations for minor issues, wherein the patient is having itching or redness, but actually it's not a surgical indication. You can still manage them with medications. So if you are able to identify that with a simple picture which the patient is able to take from their home, you're saving so many costs for the hospital and as well as for the patient.
Are you figuring in a way of charging them for a consult, teleconsult?
Same as what we have the current teleconsult policy. So it can be used as an offline teleconsult business module also. I mean, we have not explored that as of now yet, but it is a potential space where you can actually go. It's like how Swiggy and Zomato have those chatbots. It's very similar to that.
That should build in. Then
Yes.
it will become a self-sustaining model financially.
Yes.
Otherwise, people will just take it for granted. They'll say most of the time they're using the COVID protocol and they say, doctor, my image looks
So coming to the last talk, I'll try to wrap it up in a sort of a faster way. So my part of the talk is merging technology with education and how we can do that. So how we can make our learning so that our practice can be more and more green. So what is e-learning? It's a formalized process. And for e-learning, we need a network-enabled transfer of skills and knowledge. But I still feel that it's not a substitute for conventional classroom teaching. There's something fundamentally much more engaging about classroom teaching, especially in smaller groups, that this can't substitute, but it's better. It'll cut down on the environmental carbon footprint, as you saw, compared to, and you can connect with large groups. So, for example, the carbon footprint of this entire meeting must have been huge. And in fact, during COVID times, they actually compared what is the carbon footprint of an online full academic session versus actually in physical, if everybody comes for that meeting, for example, academy and so on. And obviously that the carbon footprint was very high for any physical meeting, obviously. So, so it'll have obviously a lot of technology going into it. The first platform that we at LV Prasad at least we were using and we were familiar with it was from 2017, but it became phenomenally popular during COVID times. And the Echo Clinics is a great e-learning platform. I'll just take you through a short video on the Echo Clinic, which is self-explanatory. There's a video in that. Can you play it, please?
Project ECHO, delivering specialist medical knowledge to regions most in need. It spreads new medical knowledge from specialist hospitals and academic institutions to district hospitals, community health centers, primary health centers, and sub-centers. Rather than medical expertise residing in specialist hospitals or academic institutions, healthcare providers learn from specialists. They learn from each other, and specialists learn from healthcare providers as new best practices emerge. Under the ECHO model, healthcare professionals participate in case-based learning with expert mentors. They acquire new skills that allow them to treat patients that would otherwise need to be referred on. Patients with chronic, complex conditions get high-quality care closer to their home from providers they know and trust. No waiting months to see a specialist. No stressing over getting the right medical aid. No long trips back and forth to hospitals. No spending money on tedious travels. Project ECHO, revolutionizing medical care and education in India. Are you part of the ECHO?
So anyone can utilize this platform if they want to connect with
Project
people of their specialty or with other specialties, and this works very well if you have a lot of comprehensive general physicians and they see complex cases, so they can get on board with specialists from another center, and that's how it works for the patients. What we have been using it as, we have a central hub, and we have been using it pre-COVID also, but it worked very well when COVID came by. And so, for example, we have our Cornea Institute where all our classes at one point were run on the ECHO platform, but now we do it once a week. And this is we have Echo Microbial Clinic or Infectious Keratitis Clinic once a week, where we have various centers collaborating from Delhi, from our other centers across the network. So, and even from our past fellows who are now in Burma and so on. We have on refractive surgery, eco-topography clinic, where we explain some complex subjects like topography, corneal topography, and similarly eco-keratoplasty, as well as resident eco. So these are various platforms that we can run on the echo clinic, echo glaucoma, echo whatever subject that you want. And this is a growing session where the number of sessions have been going up, the directives have been going on, and we have the cases can be bilateral. Either we present or specialists who want opinion of people housed elsewhere, they can present the cases. So these are just some snapshots of how well the clinics run. Especially the residence clinic is very popular because in many states the resident education program is still very deficient. So that's why this program is the timing is such that most residents can join this, and at sometimes we even have hundreds of residents joining into this clinics. So the other way in which we can teach without having a conventional classroom is called the flipped classroom technique. Here, course material is sent ahead of time. The presentation that I'm going to, whatever I'm going to speak on, for example, is shared ahead of time. And multiple choice questions are prepared, and those are then answered by the students. And then when it's the actual case, that the timing, the slot for the case, there's a brief presentation by the student, and the MCQs are already evaluated by the course instructor. Let's say if I was taking the course, and then the knowledge gaps that each student could not answer is then taken. So there's a much more powerful way in which they learn and own the subject. So this is, for example, how it is done. Let's say if I'm
flipped classroom teaching. I'm going to take you through one of the assignments that I had was to take a lecture on immune-mediated scleritis for my residents this month. So my homework was first to prepare the presentation, but instead of giving the presentation, so what I do is I prepare it ahead of time. Approach of the next thing that I do is to go ahead and share the presentation as well as a lot of course material, which included some book chapters and some online resources as well as review articles on the subject to the residents. So a couple of days after that, what I do is I then just go ahead and prepare a quiz, which is very simple to do on Google Forms. And this quiz would kind of cover the syllabus that I had sent to them earlier and kind of assess or gauge how much they've understood the topic. Also include some clinical photographs from patients, so it makes it more interesting to them. So once the resident answers all the questions in the quiz and submits it, the next thing that I can do is that the entire document would come to me as a report. And in this report, I can see that who are the residents who have scored not as well, and some residents have scored pretty well, and the average would be around about 15 or 16 for this entire group. So when in the 1 hour that I actually spend with the residents during the time that I have to discuss the topic, we can go through all these points and all the problems that they couldn't understand. So this kind of flipped classroom teaching using e-resources, it makes teaching very fruitful and engaging to the students. Flip.
The other e-resources we have, of course, are e-libraries, shadow websites, and of course friends and colleagues. These are many on-site online resources that are there, as well as PubMed and Google Scholar. But of course everybody now is talking about ChatGPT and other AIs. They touted to be the revolution in AI assisted learning, and this is an artificial intelligence chatbot. So it was launched, the latest version, in November 2022, and already it's been taking over. How much can we use it for our medical learning? It's yet to be seen, and there's still a lot of errors that come up, and you can't afford to have errors when you use something for medical learning. So it has to be fine-tuned. It uses both supervised and reinforcement learning techniques on the AI model. So that's all I had to share about e-learning. Thank you.
One thing we need to do is how to take this to the larger, same information what we discussed today. So to a bigger group, either making part of the resident learning program or students, or the companies. So thank you all the participants and the audience who were aware and had come with interest, and we'll hand over to the next session. Thank you.